So let's start up by talking about HIV. Have you guys covered this at all in ID yet? Not yet. Okay, bits and starts maybe. What is HIV? The virus. Yes, very good. What else? We have lots of viruses that are out there. Okay, it's a human immunodeficiency, so it affects humans and it causes immunodeficiency. Correct. Yes, this is what it does. Absolutely. It's a retrovirus. What does that mean? It's like from the 80s, man. That stuff is so retro nowadays, right? Right. It's going to be able to sort of code its RNA into DNA that then gets injected into our DNA, and guess what? Now we're doing the work of the virus for it to help all this replication and whatnot. And so we'll specifically talk about which cells we're looking for there. There are different varieties, so like HIV 1 and 2, and depending where you are geographically, that can make a difference in terms of which ones are more predominant. And in some rare cases, there's like one medication in particular that only works for one variety or the other, but you'll find most of our meds tend to be non-specific and they can work on both of them. Is resistance going to be an issue with HIV? No, you don't think so? It is of supreme significance because of the fact that you're going to find that this is a very sort of sloppy virus in terms of when it replicates. It's going to cause a lot of mutations that occur. And so resistance is a big deal. And so we'll talk about why it's important to talk about our medications and having a lot of different varieties there and making sure that we're not going to lose options in terms of which medications we can use for them. Because you can find in some cases the virus will become resistant to an entire class of drugs in some cases. And if you think about it, there's not a ton of new HIV drugs coming out all the time because this, again, is not as big of a market as something like diabetes or hypertension or something like that. So typically it's going to be transmitted through sexual contact, but how else could it be transmitted? Yeah, mother-baby, so perinatal transmission. What else? Yeah, blood transfusions, right? Is one that does not happen all that too commonly nowadays, but it used to be more frequent. What else? Yeah, needle sharing is a big one as well. Yeah, so you can definitely, we'll talk about Hep C a little bit later on too, and that's another big one that gets shared through needle sharing and whatnot. So certainly there's a lot of reasons why this can happen, why patients develop HIV, but once they have it, and we're going to learn how to actually treat that specifically. We'll also get some cases of pre and post-exposure prophylaxis to hopefully prevent people from actually developing the disease in the first place. We'll talk about some strategies for that as well. We care about this because, again, is it the virus itself that kills the patient? No, it's usually the opportunistic infections they develop as a result of that immunodeficiency. And again, when do you make that transition from HIV to AIDS specifically? It could be due to CD4 count specifically reaching a certain threshold. What else? You get an AIDS-defining illness. So something happens where you actually get an illness that is related to the HIV itself. So that's when it kind of converts over, so to speak. So we're going to be seeing these target those cells that express the CD4 receptor. So those tend to be things like monocytes and T lymphocytes. Again, the virus is going to take over take over the cell in terms of what its main functions are going to be doing, and eventually leads to that cell death, which is why you end up seeing those cells being depleted. And again, CD4 count is going to be one of the big things we're monitoring for in terms of how efficacious our regimens are going to be there. And of course, we'll talk about some of the opportunistic infections. There are many different ones out there. Things like PCP, actually should be PJP pneumonia, toxoplasmosis, different things like that. They're going to be out there. We'll talk about briefly. And so the reason why we talk about it here is because the mainstay of therapy is going to be pharmacologic. So we're going to go with our highly active antiretroviral therapy, or heart therapy for them, right? And so we're going to look at different regimens. We're going to look at which combinations make sense to put together, which ones don't make sense, and talk about different ways we can talk about, genetic testing for the virus and see which ones may confer resistance. We'll talk about all of that as we go forward. So this is a good slide here, I think, to kind of review the life cycle of the virus, and it will also help you to identify different spots where your medications can come into play and be effective in helping to prevent replication of the virus itself. So typically what you're going to find is that we'll have the virus coming in, it will end up fusing with the cell membrane of our CD4 presenting cell, right? So as a CD4 receptor there, you're going to see that this is where actually we can have some drugs prevent this actual fusion from occurring. We can prevent the virus from ever actually kind of fusing its membrane with ours in order to inject its RNA into the cell itself. Once it's there, you're going to see that it gets converted back over to DNA, and then you're going to see that this process itself of producing all these nucleotides and incorporating them into DNA can be inhibited. So we're going to look at things like reverse transcriptase inhibitors. These will be drugs that actually prevent the enzyme reverse transcriptase from converting this RNA over into DNA. We'll then look at a set of drugs that work on the integration process, where it actually will incorporate its DNA now into our DNA, where our cells start to now code for the viral proteins. So the integrase inhibitors we'll look at a little bit later on that helps to prevent that step from occurring. Once the virus has now started to replicate and is producing its own proteins, it'll make this big long string of proteins that normally have to be kind of chopped up before they become sort of mature proteins. And that's where our protease inhibitors will come into play, preventing that step from occurring. So basically it'll prevent the actual virus from actually maturing by having the proteins kind of chopped up where they need to be to become functional at that point. If that does not occur, then you'll find the virus can then have a fully new copy of itself, will bud off, and then go off to infect some other cell, which is why we'll see that not only do we look at our CD4 counts in terms of seeing how competent the patient's immune system is, to see how well our drugs are working. What else do we look at? It's another like common monitoring parameter. Viral load, right? So we actually look at the number of copies of viral RNA that we can count in the bloodstream, and that also gives us an idea of how quickly replicating the virus is. If it's undetectable, that means that we can't detect it. It's fairly low in terms of replication. That's what we're going to be shooting for. We'd like to have undetectable viral load, as we'll see in just a little bit. So again, these slides are just kind of going through kind of what we talked about on the previous slide, more in a textual format. Keep in mind that not only is it the CD4 receptor the virus is looking for, there's also co-receptors that can also help to integrate itself into with that fusion step of the process there. So for instance, it might be looking for like a protein called CCR5 or a different receptor there on our cell surface that it can also help kind of get into the cell. That would be another feature we'll look at. A specific drug is going to be interacting with this protein here in a little bit. Again, as I mentioned, this is going to be utilizing reverse transcriptase enzymes, and so you're going to typically find the virus is very sloppy. A lot of mutations occur here, and those mutations can make it to where our cells, our drugs are actually going to be ineffective for that particular virus. And again, you'll find that patients who have a particularly resistant strain of virus, they can then pass that resistant strain on to other people, and you may get a virus that is going to be very difficult to treat just right off the bat in some cases, which is unfortunate. But we'll look at some standard empirical therapy and ways to manage that. So once it forms that double-stranded DNA, that's when the integration step is going to occur, then get incorporated into us. That's going to be a really important step, and actually a lot of the first-line regimens are going to be focusing on medications that help to prevent that integration step from occurring there. But then once the virus is produced, the proteins undergoes steps with protease enzyme to help kind of chop it up into mature proteins. You will then have a mature virus that can then bud off and then go do the same thing to the next cell. And that's what we're trying to prevent, right? So you'll see there's kind of three main stages of infection with the HIV virus, and acutely they can develop sort of this acute retroviral sort of syndrome. It kind of looks like mono a little bit in terms of their reactions there, and they may have a sort of a latent period for a period of time where they may have no signs or symptoms of the disease whatsoever, even though the virus is sitting there kind of quietly sort of replicating and infecting a number of cells. Then we kind of get into more chronic management for these patients. Once they have the diagnosis and we're actively treating them, they can kind of hit a nice kind of latent phase where hopefully they have good suppression of the virus, their CD4 counts stay high, and they shouldn't really end up developing a lot of opportunistic infections in those cases there. And then finally we get sort of the terminal sort of period here where they develop some sort of AIDS-defining illness like Kaposi's sarcoma or PCP or something like that. We'll look at some ways we can maybe help prevent that in some cases, or ways we can treat that. As I mentioned, CD4 count we want to be elevated, right? We want that to be high. Viral load we want to be undetectable, right? So if you can detect any at all, that's not a good sign. You want it to be completely undetectable. So our goals here are to decrease morbidity and mortality for these patients. Now, when did sort of HIV, AIDS, when did that sort of become a thing in terms of timeline? Back in the 80s, right? So mortality with HIV back in the 80s was quite high, right? So I know we covered it briefly in the EpiBio class. We talked about how a large percentage of those patients diagnosed frequently died early on. You guys watched that movie the band played on? Yes, right? So that kind of talks about that. It seemed kind of like sappy in the moment to kind of watch it, but kind of in retrospect, when you kind of know more about it, it's really kind of fascinating to see how all of that started up. There's lots of other documentaries talking about developing new medications early on in the 80s. Nowadays, what's mortality like for these patients? A lot less, right? So it's not zero, but it's a lot less than it used to be. And a lot of it depends on compliance with medication regimens. It depends on a number of factors there. But the interesting thing nowadays, and again, it's only been, 30, 40 years now, we're starting to see that these patients aren't necessarily dying of complications of the virus itself, but now they're having issues with complications of the medication regimens. We'll see that a lot of the medications we're giving these patients can have a lot of metabolic consequences, so now they're developing things like heart attacks and diabetes and all these other things that we're now having to treat that are going to be secondary effects of the medications we're giving them. So it's kind of an interesting change in terms of kind of the modality here we'll see. So anyway, we want to preserve their immune function as best we can, prevent those opportunistic infections from popping up, prevent transmission if possible, right? So especially if you have like serodiscordant couples where one patient has and the other one does not, trying to prevent transmission if possible. We'll look at some ways to do that. And then not only that, but if you imagine like as a healthcare worker, might you be at risk for developing one of these bloodborne diseases? Why is that? You stick yourself, you cut yourself with a scalpel, something like that, where the patient has HIV, you could potentially be exposed. And we'll talk about post-exposure prophylaxis in those cases there for high-risk patients. I don't know if I ever mentioned the story, but my first rotation in pharmacy school was at a community site where we had like a Coumadin clinic. And the first patient I had to do, we were doing point-of-care testing for INRs, right? So we were checking their INRs, make sure they're in range, we'd adjust their doses. And so the first guy I had to do it on had HIV, Hep C, had AFib, and been on warfarin for like years and years and years. We'll actually find there's a lot of drug interactions that come about from the HIV regimens. A lot of them will cause CYP interactions and whatnot, we'll see. And so he was very difficult to keep his INR in range. We have to always come back. Point being though is this was like, this is in Palaca, Florida. This is like people that work with their hands all the time. They grow their own food in a lot of cases. This guy had very callous fingers. And so as you might imagine, it was very difficult to get a stick on this guy with a little point of care, little sticky thing to actually get the INR, to get blood to do the INR. And so anyways, I'm sitting there and of course I'm like, my first like patient, like actually like having to touch, on rotations, and I stick them and I'm trying to get this blood out. I'm just like trying to milk all this blood. I'm like, this is going to squirt in my eye. This is going to squirt in my eye right now. And I'm going to be having post-exposure prophylaxis. It didn't happen. Obviously that was ridiculous. But point being is until you know, you don't know, right? But so our purpose here though is again, keep their cell count high, prevent transmission, keep the viral load as undetectable as long as possible. So, interestingly, you'll see that this has changed over the years. Back in the day, when do we decide to actually treat a patient with HIV?
Which day?
Which day? Like say like back like in the 90s or something. Okay. Like did we start off like as soon as they got a diagnosis, did you start treating them? So certainly they present, because maybe they went a long time without ever being diagnosed and they're presenting with an opportunistic infection, absolutely you'd start then, right? Frequently for patients that had not developed an opportunistic infection, you'd actually wait until they got down to a certain CD4 count. And the reason being is we didn't have as many drugs that were out there, and we thought that, okay, well by waiting until they reach a certain threshold, then we maybe can preserve and maybe use these medications for a longer period of time. However, nowadays realize that's no good, right? Realize that putting the patient at too high a risk, maybe you're spreading to other people unintentionally. So nowadays, as soon as you get a diagnosis, you start treatment immediately. And so that's a really important feature that is now what we're doing nowadays. We now know that that's the smart thing to do. And again, you'll find that if you even look back with a few years in terms of recommendations, that this stuff changes all the time. So you absolutely have to kind of keep up to date on this stuff in order to be sort of up with the latest trends, because it always changes. Now, how many of you are going to specifically work with HIV patients all the time? Maybe not many, but are you likely to encounter patients with HIV? 1000%, right? So again, you need to at least know what kind of medications they're on, what sort of implications that can have. You may be seeing them for something completely, unrelated to HIV specifically, but maybe related to the medications that they're on that have caused them to see you in the first place. So you need to be cognizant of it. So anyway, so again, we're going to go ahead and put them on this heart regimen, get the viral counts undetectable, keep their CD4 count as high as we can for as long as possible. You'll see here that we're typically going to use at least a 3-drug regimen. It's actually recently changed. I'll show you a slide that actually shows a 2-drug regimen that has some efficacy, but for the most part, most patients will at least be on a 3-drug regimen, if not more, okay? So as you might imagine, compliance is going to be very difficult for these patients. Also, think about the social settings that they're in. Perhaps they're in a social setting where that is not going to be as easy. If they're, say, homeless or they're IV drug abusers and things like that, it can be more difficult in terms of compliance. So this is always going to be a challenge for these patients here, because guess what happens if patients are not being very compliant to their heart regimens? The virus is going to get resistant, right? Because again, you're putting some selective pressure on the virus, but you're still letting it kind of grow because you're not being consistent. You're going to get more resistant bugs, right? And so this is going to make it more difficult to treat down the line. So as I mentioned, in terms of optimal time to treatment, we now realize that it's good to start as soon as you get the diagnosis. This helps to reduce transmission and overall helps to reduce the number of AIDS-defining events that actually occurs in those patients. So that's why we do not like to delay therapy any longer. But even when I was in school, a scant 10 years ago, which is again crushingly depressing to say, but even then it was like, no, you wait down until they have a CD count of like 200 or something like that, or whatever the regimen, or whatever the count was. They said once you get to that point, then you start regimen. But soon after, then they were like, no, let's just go ahead and start for everyone immediately. So we'll look at the different drug classes we have available to us. Here's just a list of them that we'll get into more specifically. If you recall back when we covered the oncology medications, you remember the drugs had a lot of abbreviations we'd use for them. It's like cytarabine was like Ara-C, and for instance, like methotrexate is like MTX, and you saw a lot of those. This is the same thing. You'll find a lot of drugs will have a lot of abbreviations. I'm not going to have you memorize those. I will not present them on the test, but I just want to give you some exposure to that, because you'll find people that work with HIV all the time, like they know them just by their abbreviations, and it can be really difficult to have a good conversation with them, because they're like, oh yeah, patient's on DD4 and AZT, and you're just like, I have no idea what any of that means. And you'll realize that some of the drugs don't even seem to correlate with a lot of their abbreviations, as you'll see in just a few moments. So anyway, so I want to start off first with the nucleoside or nucleotide reverse transcriptase inhibitors. These are NNRTIs, not to be confused with what we'll see in a few minutes will be the NNRTIs. Again, it can get a little confusing here, but it's important to be able to distinguish between classes. So basically, these are going to be working as sort of mimics of purines and pyrimidines, and the point being is that they're going to get incorporated into the viral DNA, and they're going to act as those chain terminators. So this is very similar to what we saw with something like cytarabine when we did for oncology. Oh my goodness, the cacophony of clicking just went up greatly. But basically, they're going to get added on to that, and they cannot add on any further, any more nucleotides to that point. So again, once the DNA is sort of inhibited, can't reproduce itself, then it just kind of doesn't do anything. It dies off at that point. So I'm not going to have you memorize whether they're thymidine or deoxyguanosine analogs. I just want you to be able to recognize these as an NNRTI. This is already going to be a tough enough class of drugs anyway, because again, most of the time, how do you tell a drug is an antiviral drug? Where does it end in? And in VIR, guess what? A ton of the different classes are all going to end in VIR, and so you're not going to have an easy time being able to recognize them just based off of that. Sorry, I didn't name the drugs. I wish I did, because that'd be a lot easier if I could do that. But and just to give an example of some of these abbreviations, like stabiline is D4T. I don't know how I came up with that. Actually, probably has to do with the chemical actual structure itself, the actual chemical name. But you can see here that zidovudine is AZT. That's actually a pretty common one you'll see quite frequently. This is actually the first one that we had on the market back in the 80s. It actually was pretty revolutionary at the time. But we have things like emtricitabine, lamivudine, abacavir, didanosine, and tenofovir. And again, not all these are created equal. You'll see that some of the newer ones, which we'll look at in a moment, actually have a little bit better side effect profile, and those tend to be sort of the backbone to a lot of these regimens. So most of the regimens you're going to see will include an NNRTI backbone, okay? Meaning at least 99% of cases you're going to have two of these drugs being used together in addition to a drug of another class, okay? So these are going to be the backbones of your heart regimens. And again, if you imagine here's the enzyme reverse transcriptase. The viral RNA is coming through. If you imagine kind of clapping on one of these false nucleotides like zidovudine or something right onto the end of the DNA, it cannot elongate any further, thus you don't have any functional DNA to get incorporated into our DNA. Thus the enzyme or the virus cannot replicate at that point. Again, that's probably as far as you need to know in terms of the mechanism there. It's blocking further DNA production. This will be important though to delineate between the NNRTIs versus the NNRTIs, and I'll show you what that looks like in just a little bit here. But again, these sets specifically work on the actual DNA. So frequently you're going to find that not only are you looking at what the virus is sort of susceptible to in terms of like drug therapy, but you're also thinking a lot about the side effect profiles. And these drugs, in general, in terms of HIV, tend to have a pretty nasty side effect profile, especially some of the older agents we'll talk about briefly here. But a lot of times you'll see here that it would be nice if these drugs had 100% specificity just to the viral targets, but you're going to find there's going to be a little bit of a bleed over effect, right? So again, you're going to find some effects on our cells as well. So for instance, here you can see things like mitochondrial RNA and DNA synthesis can be affected here. What type of cells do you think might be affected because of that? a lot of rapidly dividing cells, kind of analogous to when we were talking about our chemo drugs. So if you might imagine, you can see a lot of things like GI side effects associated with this. Like I remember talking to one patient who's on didanosine. He was talking about how severe the diarrhea was with that particular medication, that he couldn't even make it to the bathroom most times. But it was like the only drug that was working for him back in the day, when that was very limited in terms of options. So it was like, okay, well, I either die from AIDS or I deal with this diarrhea. Not a great trade-off there. So fortunately, some of the newer agents, which you'll see a lot of the newer regimens will recommend these, include things like abacavir, tenofovir, emtricitabine, and lamivudine. And that'll make sense when we go over some of the sort of initial regimens that they recommend. A lot of them will include, 2 out of these 4 drugs listed here. Other things you can run into include things like peripheral neuropathies that can develop over time. You can develop anemias, which kind of makes sense based off that rapidly dividing cell thing we talked about. And then lactic acidosis associated with a fatty liver can happen, pancreatitis, a lot of GI effects that can come about from these medications here. One thing that's really unique to abacavir specifically is you have to test the patient for this polymorphism, this HLA B5701. And again, you'll just be able to recognize that as HLA protein. Like I'm not going to give you on a test, like is it HLA B5701 or B5706? Like I'm not going to do that, right? But I expect you to know that with abacavir, you have to test for this particular polymorphism. The reason being is that if you don't, and the patient has this polymorphism, they're very likely to have an anaphylactic reaction to the drug, right? And so that's just something we can relatively easily test for and know whether those patients are going to be a good candidate for that drug or not. If they have the mutation, don't give abacavir. And you'll frequently see abacavir is not going to be listed as like a first-line drug, maybe as a secondary after one of the other ones have possibly failed. So switching gears and talking about our NNRTIs, or the non-nucleoside reverse transcriptase inhibitors. By their name, you can say, okay, well, I know they're not going to be false nucleosides, right? They're not going to get incorporated into the DNA specifically, but they're still inhibiting reverse transcriptase. Well, how do they do that? Well, essentially, the drug itself is going to kind of bind to the reverse transcriptase enzyme, and it changes the conformation such that it doesn't interact with the viral RNA any further. So again, you're finding that no new viral DNA can be produced because you're inhibiting the enzyme itself from working on that viral RNA, okay? So would it make sense to combine an NNRTI plus an NRTI? You do get some synergy there, right? And so you'll actually find this is an acceptable regimen potentially, is to combine the 2 together. 2 NRTIs plus an NNRTI, right? Again, it sounds confusing. It's like alphabet soup after a while, but again, that's why I record these so you can go back and review it, or you can go to sleep, or whatever you want to do with my videos. But I actually did see my channel was trending on the ASMR, kind of group, so that was pretty exciting to see there. So, if you don't know what that is, just look it up. It's kind of weird. But so NNRTIs, a couple of drugs in this category include dolaverdine, efavirenz, nevirapine, etravirine, and then rilpivirine. These ones tend to be a little bit better tolerated than, say, for instance, like the NRTIs, depending on, especially the older ones we were mentioning there. You can see some rash. You definitely want to monitor liver functions with these as well. Liver in general is going to be good to monitor for these patients regardless of which set of drugs are going on for the most part. So you're going to want to monitor that baseline, and then as treatment goes on. Again, what else are these patients at risk for contracting as well? Hepatitis C, right? So is a frequent one, hepatitis B potentially, but hepatitis C for sure. And again, that can also be kind of clouding the picture as well, maybe helping your drugs to not get metabolized as well. What's interesting with this class here, though, which makes it kind of problematic, is it's very susceptible to resistance. So for instance, except for etravirine, if you have one specific mutation in the virus, it actually confers resistance against all of the other ones, right? So it's like, okay, well, maybe you're taking dolaverdine, and then all of a sudden you have the mutation, come back, say the viral count's starting to go up, you go back and do, say, some testing for susceptibility, all of a sudden you realize that all of the NNRTIs, except for etravirine, are going to be ineffective, right? Not great, because that then limits your options pretty significantly. So again, back before we had another set of drugs we'll talk about later on, this is kind of what we had, or one of the cornerstones of what we had, and so we just had to be aware of the fact that, they need to be really compliant with this stuff, because if they're not and they develop resistance, then they lose that whole class, which is not great. So Up next, we have our protease inhibitors, and so these are going to be drugs that basically, once the virus has sort of integrated its own DNA into ours, and now we are producing the viral proteins, they kind of come out in the immature, sort of uncut state, and so protease will come along and then chop them up into the actual sort of mature proteins, and that way they're ready to bud off and go off and infect another cell. These drugs specifically are inhibit that protease enzyme such that the virus never becomes mature, right? So pretty straightforward in terms of mechanism. Here you're going to find several drugs that fit into this category, so things like atazanavir, darunavir, fosamprenavir, we have indinavir, we have lopinavir, nelfinavir, ritonavir, sequinavir, and then tipranavir. A lot of virs there, right? And again, I wish all the virs just fit into one category. You say, oh, that's a protease inhibitor. Not going to be quite as easy. Again, make quick associations. Just do like a flashcard that just has like atazanavir, and on the back it says protease inhibitor, right? Be able to make those quick associations for testing purposes. Because again, I'll ask you a question on the test. It'll be like, which one of these is an acceptable regimen for, you know, HIV, initial therapy for HIV, and I may put like 3 protease inhibitors on there together, and you'd be like, well, that's not right, because that's 3 protease inhibitors, you can't use that as an initial regimen. Again, we'll cover what is appropriate as initial regimens later on, but I'll tell you right now, 3 protease inhibitors, not going to be it. You need to be able to identify the drugs so you know what category they fit into. So, and this one's kind of interesting too. So we have a brand name called Kaletra that actually is going to be lopinavir plus ritonavir, and it's like, wow, why would I use 2 protease inhibitors together? Interesting. We'll look at some interactions that actually can help us out in just a little bit. So protease inhibitors themselves tend to be pretty negative in terms of the metabolic effects you'll find for these patients. So certainly you'll see some GI distress, but you'll see things like increased lipids, you'll have glucose intolerance, and you can actually have some lipodystrophy. So it's not uncommon, or it's kind of unique to the protease inhibitors that will cause this buffalo hump sort of lipodystrophy you can see here on this patient. So this is the thing you have to think about. These patients are living for a lot longer, you know, before maybe they don't have a few years after diagnosis before they acquired some, you know, AIDS-defining illness. Now they're living for decades potentially, and now you're seeing that they can develop a lot of secondary complications, like now they have type 2 diabetes, now they have heart disease, now you're having to manage it along with their HIV. So again, the comorbidities can be really important, especially the longer they've had it. So the kinetics here are really important in terms of the protease inhibitors. So most of these are going to be metabolized in the liver. In fact, most of the drugs we've looked at so far have been through the liver. But what we can do actually is to utilize a drug interaction to our own purposes. So a lot of the protease inhibitors you'll see will have some interactions with CYP3A4, but ritonavir in particular, and this other drug called cobicostat, tend to be pretty strong 3A4 inhibitors. So that actually will boost up the levels of a lot of other drugs that are substrates for that. So for instance, with like lopinavir, I can give it along with ritonavir. It'll inhibit that CYP3A4, and now levels of lopinavir have now elevated. Is that a good thing or a bad thing, you think? Was the formulation of the two together, so you would assume, well, they must be marketing it for some reason, must be a good thing. Why is that? So levels are higher, you get better suppression of the virus. What do you think happens in terms of like dosing frequency? Goes down because levels are higher, it sticks around for longer, such that you find that you can actually give the drug less often. So instead of, say, giving it twice a day, maybe only give it 1 time a day. Again, what does that do for our compliance? It gets better, and what do we already say is difficult for a lot of these patients? Compliance, right? So again, this is overall a good thing. So you may see that this is where you get like a 4-drug regimen from, is where you're utilizing something like ritonavir, not as an anti-HIV drug itself, but you're actually using it to boost up levels of other drugs, and that helps to decrease the total pill burden that a lot of these patients have. And in fact, I remember like watching this old like news clip, news video that was talking about a patient with HIV, and it was like they just had like, it was like back in the 90s at some point, and they just had like dozens of pills they were taking a day, and it was like really problematic because like half their day was just designed or just around taking their medications when they should. A lot of times nowadays we have medications that are combination drugs. They can just take 1 pill a day in some cases. That's really helped out in a lot of situations with compliance. But this is a case where we can use the kinetics to our benefit to boost up these other drugs. Again, make sure you're looking anytime you're adding on a drug to a patient who has HIV that is on heart therapy. Please double check, do an interaction checker, because you can really screw something up either with the medication you're adding on or with their heart therapy itself. Because again, if I were to give something like a CYP3A4 inducer, say something like added phenytoin onto a patient, maybe they develop seizures, give them phenytoin, it was inducing CYP3A4 and dropping down the levels of their protease inhibitors, what's going to happen? Well, the viral load could go up because they're not suppressing the virus correctly anymore. The CD4 count could go down. Maybe they get opportunistic infection. These are things you have to watch out for, right? So The next class here is going to be our fusion inhibitors. So this is going to be sort of an add-on, maybe probably not first line set of drugs you're going to use here, maybe third or fourth line potentially. These are our fusion inhibitors, and they will prevent the actual virus itself from fusing with our cell membrane to inject its contents into our cells. This one is specific that it only works for HIV-1, has no activity against HIV-2. So in some places in the world, you'll find that HIV-2 is more predominant, in which case this drug would not be all that effective. So you want to make sure that you're using it for patients that have HIV-1 specifically. And again, frequently what we do as soon as we have a diagnosis in a patient is we're going to do testing to find out specifically what type of HIV they have, and then also it's going to be checking out susceptibilities and mutations and whatnot. We'll talk about that a little bit later on. This one is an amino acid. It's a peptide, or a 36 amino acid peptide that gets injected. So it's going to be one they have to give subcutaneously. What could be a potential complicating factor with someone with HIV injecting themselves? If they're immunosuppressed, they could be at risk for skin infections and things like that, right? So making sure they're cleaning appropriately, really important. All the other agents we've already talked about have been oral, but this was the first one, sub-Q, that we've seen so far. Other things you can find, pain, erythema, nodules can develop, so make sure they rotate sites around in order to prevent any like scar tissue and things like that from popping up. Next, a very niche sort of drug here is a CCR5 Antagonist. And so we mentioned that normally the HIV virus is looking for the CD4 receptor on certain cells like your T lymphocytes in order to get in and cause that fusion to occur. A co-receptor that the virus is also looking for that helps aid its entry is going to be the CCR5 protein. And so you're going to find that if your patient expresses the CCR5 protein, this receptor, that it will actually be able to aid the virus to getting in. And so this is actually the first drug we had for treatment of HIV that doesn't affect the virus itself, but actually affects the human protein. So this will block that CCR5 and make it more difficult for the virus to come in, right? So you have to make sure that you're looking for the correct strain of virus, though, to make sure that if the virus is not looking for that CCR5, then it's not going to really be all that effective, right? So, for instance, if you have a patient who did have a virus that was looking for that CCR5, you could put them on this for a while, but again, the virus is going to mutate eventually. It may lose that aspect and not want to look for that CCR5 anymore, then it doesn't really matter. So you could take them off the drug at that point. Again, it's nice because it's pretty well tolerated, no big issues, but again, watch for liver function tests. It's going to be pretty ubiquitous amongst most of these. The next set of drugs, this is really becoming pretty important in terms of a lot of the initial regimens. It's also one of the newer ones we're seeing here, but these are the integrase inhibitors. These are going to be ones that actually prevent the integration of the viral DNA into our DNA itself. And so we have things like raltegravir, dolutegravir, elvitegravir, which actually that one's another one that gets co-formulated with cobicistat as a booster. And then bictegravir. And so this is probably the newest one out of the groups here. And so as I mentioned, they're going to bind to the integrase enzyme to prevent that viral DNA from getting incorporated to our own chromosomal DNA at that point. Again, another nice thing and why these are frequently recommended as first line is because they actually are pretty well tolerated. They get some rash, nausea, headache, but not a whole lot of other big issues other than that. So this is probably going to be what a lot of patients get started off on as initial therapy, as we'll see in just a little bit. So, as I mentioned with the drug interactions, they are numerous. Sometimes they are on purpose, as I mentioned with like the ritonavir or the cobicistat. We're using that for boosting purposes. A lot of them are going to be through the CYP3A4 though, so you want to be watchful for that. So, but they're not all going to be inhibitors. So for instance, some of the NNRTIs can actually work as an inducer of CYP3A4. Right, so that would be bad if it was interacting with something that was going to be inhibiting, or something that was actually being a substrate there, because those levels would then drop in those cases. Most of the protease inhibitors will have some inhibition of CYP3A4 though, so that's one thing you'd want to note there. And keep in mind, like, imagine some of the opportunistic infections these patients may be at risk for, things like TB. Well, what happens if we put that patient on rifampin? Rifampin is a CYP3A4 inducer, and will actually drop down levels of things like your protease inhibitors and whatnot. So again, it could be problematic. You may need to say, look for an alternative to rifampin, look for something different that does not cause the same sort of interaction there. Look up food-drug interactions. I'm not going to get into every single one of them, but just be aware that some foods are better absorbed in more acidic environments, some get better absorbed in fatty foods. So just be aware that those changes can occur, and when in doubt, look it up. If you take nothing away from my hours and hours of lectures you've had to listen to, but just one thing, look it up, please. Just please look it up. Anyway, so treatment is going to be an evolving process for these patients. You're going to find that new recommendations are always coming out. I had to update this lecture just for this specific recommendation because it's actually kind of a new one to me as well. Go to aidsinfo.nih.gov and you can find all the up-to-date stuff. They have a ton of different really great guides for treating adolescents, treating pregnant patients, everyone you can imagine. Any guide that's out there is available. And again, this is a really big source of a lot of research. So there's always new stuff coming out all the time. So what we do know in terms of initial treatment for most patients is you often want to start off with a 3-drug regimen, and it's going to include 2 NRTIs, so maybe like emtricitabine and lamivudine, for instance, and then you would add on a 3rd one of a different class. So for instance, I could do an integrase inhibitor plus 2 NRTIs. So I could do something like raltegravir plus tenofovir and emtricitabine. Or I could do, say, a protease inhibitor plus 2 NRTIs. This is where you may get into more of those 4-drug regimens. So for instance, if I do darunavir plus ritonavir as a booster, then do 2 NRTIs, that does make total sense there, right? Ritonavir is typically used as a booster, not as its own individual antiviral agent itself. Or, which is less preferred, mainly due to resistance issues, are going to be using an NNRTI plus 2 NRTIs. Back before we had the integrase inhibitors, it was really either one of these 2 categories you're going with, but nowadays I'm starting to see many more recommendations saying, hey, start off with an integrase inhibitor, because it's better tolerated than a lot of things like your PIs and your NNRTIs are. Thought I had one thing here. Did I forget to include that? Oh my goodness, I did. There's one thing that actually came out recently. It was on the AIDS Info website that said that basically you could have a 2-drug regimen, and I believe it was saying you could do bictegravir plus lamivudine. And they actually found in clinical trials that had very similar activity to, say, a typical 3-drug regimen. So just to give you an example, that's going to be changing over time. You may find that as resistance patterns change, as new drugs come out, you may find that, hey, maybe a 3-drug regimen, maybe 5-10 years from now, that's going to be outdated stuff, and maybe we just have 1 drug we can give to these patients. So always be aware to kind of go back and check and look stuff up. Okay. As I mentioned, adherence can be pretty variable depending on the patient, and so this is ultimately what's going to determine if the patient develops more resistant virus, if they're going to be successful or not, is how well compliant they can be. And in some cases, I've talked to some practitioners, like some pharmacists that just work in an ID office, an ID clinic, just with HIV patients, and they'll say, listen, if you're even expecting to miss like 1 or 2 doses, like don't even bother with this drug, right? Because once it becomes resistant, then you're out of the whole class, for instance, with like the NNRTIs. So education is really important. Getting them appropriate services to help out with their other concomitant issues is really important as well. So do they have underlying psychiatric illness? Do they have substance abuse issues? Making sure you're counseling on the adverse effects to let them know that, hey, these are expected, these are normal, and look, here's what the benefits are going to be in the long run if you stick with it. Of course, unstable social circumstances, what kind of resources do they have to help pay for these things and whatnot, all very important factors there, right? So a lot of these clinics will have a big team sort of dedicated just to that to make sure these patients are well taken care of. So in order to help with the adherence, we want to make sure they're using combination formulations whenever possible. So if we can give them less pills they're taking in a day, that's always going to help. And also maybe help to limit some of the food restrictions you might run into there. So for example, you may find things like efavirenz, emtricitabine, tenofovir all together in one drug called a tripla. That way they could just take 1 pill a day. Or for instance, like eltegravir, elvitegravir, cobicistat, emtricitabine, tenofovir. Again, I don't expect you to memorize which ones come in combination, but I just want you to know why we do that, and that there are options available to your patients and may be beneficial, right? Anytime though they put a new combination together, they get a new brand name on it, guess what? It's going to be expensive for a while too, so you want to be cognizant of that. If your patient can get, insurance and things like that to not have to pay for it potentially. Because again, these patients get something like a PCP pneumonia and get into the ICU for a couple of months. That's oftentimes going to be much more expensive than covering the drug in the first place. So again, there are a lot of calculations that go into that. So let's do a 10-minute break now, and we'll come back and we'll talk about resistance testing for HIV. Let us look at the questions we have. When using 2 NRTIs, would you need to use medications from 2 different analogs? I believe that is the case. I've never seen anything stating where you would use 2 of the same, but for instance, I'll show you on the slide here, typically I see a lot of like emtricitabine and then tenofovir used together, which would make sense because you're using something that's attacking, somewhere where cytidine would bind versus somewhere like adenosine would bind there. So that does make some sense. I would probably see a lot of those regimens being used. And again, typically, you guys, if you were to say start someone on it, you'd be using one of the initial empiric regimens, which I'll show you some examples of a little bit later on, but this is like something you'd get right off the NIH website. When you're going to get more in depth in terms of switching out individual NRTIs, like that's something that's going to be more in the realm of like the ID docs are going to be handling that, or the PAs are working for them potentially, right? So that's something you may see a little bit out of your depth, but again, I always, whenever I have these patients that show up, they're not frequent, but whenever I see them getting admitted, I always look at their regimen. I was like, oh, does that make sense? And I look up all the drugs, and I'm like, yeah, totally. They got the integrase inhibitor, 2 NRTIs. Yeah, it makes sense there. Another question: what insurance cost consideration should we have with multi-drug regimens? I'm not sure what that person is aiming for specifically, but I mean, you're always looking at things like, you know, are there generics available for the particular med you're hoping to use? You know, are combination therapies going to be available? You know, trying to think of what other considerations. So depends, like, do they have any insurance available or not, or what kind of programs, kind of special assistance things? You guys ever heard of Ryan White? That's a program in Florida specifically. He was a child that actually got HIV as a result of a blood transfusion, I believe. This was back like in the late 80s, 90s, somewhere like that. But it's a system designed to help people get access to the HIV medications, and so I believe that's still ongoing, right? You seem to know something about it. Oh, it's in the movie? Yeah, yeah. So that's something I believe is still around, but it's specifically like in Florida. So where you decide to practice, there may be other options available to those patients. But hopefully I answered that question. I don't think I did, but that's okay. Okay, so resistance testing is kind of a interesting topic here. So typically when you have these patients first diagnosed, of course, just like with anything where you'd want to get like a culture for like a bacterial infection, you certainly want to get a culture and test for your virus to see here what potentially is already going to be resistant to begin with. You know, did you get a wild type virus that is basically going to be susceptible to pretty much everything, or maybe they picked up a resistant type from someone who had one already? And so in this case here, there's two varieties of testing that are important. We're going to have phenotypic testing and then genotypic testing. I'll tell you that the genotypic testing is going to be less useful overall, but it's also going to be cheaper and easier to do. And so you guys know the difference between a genotype versus a phenotype, right? What's the difference? Yeah, genotype is just like what genes they have versus phenotype being like you have brown eyes with a little bit of green in them, right? So again, it's like what those genetics actually confer in terms of like what actually happens in real life. Similar things here. So for instance, we can basically get the genetic sequence of that virus and determine what sort of genotype it has, what sort of mutations it has, and based off of a database, we can look at that database and see, okay, well, we know that typically when this virus has this particular mutation, it confers resistance against this particular drug, okay? That's one way to do it, right? So it's basically just going off a database saying it has all these mutations. We think these drugs will most likely be effective for your patient. On the other hand, though, with the phenotypic testing, this is where you actually take the virus itself and we can actually subject it to similar testing as what we would do as culture and sensitivities for, say, a bacterial infection. We can actually determine how resistant the actual virus that the patient has is to particular types of drugs, right? Because sometimes you'll find these viruses will have different combinations and mutations, and maybe they will confer resistance to something that we just couldn't predict. And that's where the phenotypic testing really comes into play. So it's more expensive, takes more time. You may do as like a follow-up to the genotypic testing, especially if a patient has a treatment failure. That's where you're going to see the phenotyping being done more frequently, I think. So, and again, you always want to start these patients off with empiric therapy regardless. You can get the testing done afterwards, right? So you can get that culture done, do the genotype, get the patient started on empiric therapy, and then if something comes back resistant, then you can switch it out if you need to, right? We'll get into the pregnancy section coming up next after this, I believe. But let's talk about HIV and pregnancy briefly here because this is important for your prescription assignment. It's also important because this is a high-risk population for perinatal transmission over to the fetus. Generally, though, you want to consider, okay, if these patients are on all these heart medications, do they have any negative impact on the fetus? And typically we'll treat these patients as if they're not pregnant for the most part. We tend to find that the best thing to do for these patients is to have maximal viral suppression, and that helps to prevent exposure to the fetus if we can. One drug you do want to avoid is going to be efavirenz, mainly due to the risk for neural tube defects, so you'd want to avoid that for those patients there. But again, patients who may be on treatment for HIV, they may also be at risk for getting pregnant. And again, there's that period of time during the first trimester where we may not realize they have that drug exposure going on. So it's something to consider there. So, and in a lot of cases in terms of prevention for intrapartum transmission to the fetus, they will also recommend using zidovudine. And so basically once the child is born, then they can give them about 4 to 6 weeks or so of just a single drug by itself, and that helps to prevent the virus from ever kind of establishing hold, if any is there. So it's a form of sort of post-exposure prophylaxis to prevent the infection from happening, and tends to be relatively effective for the most part. And then once the baby is potentially on treatment for that, they typically recommend avoiding breastfeeding for a concern of like transmission of a drug and things like that. So they try to avoid that if possible. So and then we have chemoprophylaxis, which is, what does that mean? Using chemicals to prevent the disease in the first place, right? So this is something where we'll talk about both pre and post exposure prophylaxis here. You want to think about patients who may be at high risk for exposure if they don't have the disease themselves. So for instance, like healthcare workers, the nurses, providers, things like that. The risk to pharmacists is exceedingly low, fortunately, because we get to stay back and be like, ooh, that's a lot of blood. Not getting close to that. There's a lot of people going to pharmacy because they are pretty squeamish with like bodily fluids and touching people and talking to people. I don't know what that's like, but anyway. So particularly though, if you have like something like a needle stick or say a cut or something like that, the first thing you want to do is know if your patient has HIV or not in the first place. You'd like to know their status. In some cases, you may not be able to get that patient back. You may not be able to know. And so in those cases, you oftentimes will go with the worst case scenario, right? And everywhere you work will have some sort of needle stick procedure there to make sure that one, you're protecting yourself and that you can determine whether post-exposure prophylaxis is not. This is where like a lot of employee health departments come into play, is where a lot of providers, both either like an infectious disease providers or like occupational health, they can come in and sort of do a risk assessment to see, based off the exposure, how likely it was that patient could have transmitted something to you, and then how much chemoprophylaxis you're actually going to need in those cases there. But again, if you don't know, then oftentimes they'll go worst case scenario. It's ideal to start as soon as possible. So anytime you have an accidental exposure, you want to alert someone to it immediately. Like obviously first you want to clean it up with soap and water, but next thing you want to do is make sure people are aware that, hey, this has happened, let's go and take the next steps. And so, for instance, here, these cases, one of the recommendations would be just to go to like a kind of a full court press and do a full 3-drug regimen for say 4 weeks. So you do like tenofovir, tricidebine, and then an integrase inhibitor, and then that will hopefully be enough suppression that if any virus did make it into that wound, for instance, that it would be prevented from ever establishing a hold in that patient, right? So, and again, sometimes you may be over-treating in a lot of cases. Maybe the exposure really wasn't that bad, but if you don't know, you don't know. And a lot of people get more peace of mind from going more conservative than not in a lot of cases. Here's an example of pre-exposure prophylaxis where maybe, for instance, you have serodiscordant couples. Say, for instance, you have like men who have sex with men. Maybe one of the male patients does not have HIV yet. They can sometimes actually give them a combination of daily tenofovir and tricidebine to help prevent transmission in the first place. Obviously, you want to get tested beforehand to see if the patient does have it, because if they do, then they need usual treatment just like anyone else. But other patients that may benefit from this is that they're IV drug abusers and you try to mitigate some of that risk there, things like that. But make sure they're seronegative before you start them on this sort of suppression therapy, because if someone did have HIV and I was just giving them tenofovir and tricidebine, what would be a likely result? Yeah, resistance, or I would not have active viral suppression. I would still see that hit to the immune system over time. So again, that would not be a sufficient regimen to keep that virus from replicating. So again, how we're evaluating these patients in terms of outcomes, we're looking at their CD4 count, we're looking at their RNA load in terms of how many copies of the virus we're actually able to detect in the blood. And as I mentioned, we're going to do HIV resistance testing at the very beginning. Typically genotypic testing, as it's a little bit cheaper and faster turnaround time. And then you basically monitor them every 3 months or so, make sure that the RNA levels are undetectable in those cases there. Reasons why you might switch a patient was most of the time going to be due to intolerable side effects. So like I mentioned, like adenosine and like diarrhea tend to be really severe. That may be a reason to try to switch them over to a different agent. Other reasons would be things like treatment failure. So if you still had levels you could detect, say more than 200 copies per ml, what's the other big thing you have to assess if their RNA load still comes back high? Are they taking it like they're supposed to, right? So are they actually truly being adherent to the regimen? Because if not, you may not need to switch to the drug necessarily. You just may need more education for the patient or more assistance to make sure that they can actually be adherent and successful. And then make sure you have any documented resistance to agents. You want to know what they've been on previously, why they were switched previously, and make sure that you know that you're not going to give them something that they're already resistant to potentially. So, any questions on that so far? All right, getting into some of the complications from HIV and AIDS. We know that prior to antiretroviral therapy, we saw a lot of focus on prevention of opportunistic infections for these patients. Nowadays, we just know to treat early. We know to start them off right at the beginning there. But what we do know is that as the CD4 count gets lower and lower, that they tend to be more likely to develop different opportunistic infections. So for instance, like a big cutoff point is they get below 200, their risk for PJP pneumonia tends to go up significantly, right? And so you're going to see that depending on what their CD4 count is, we may either start up initial prophylaxis for some of these disease states. If they develop the disease, obviously we're going to start treatment, and then once they're treated, they may actually go on sort of secondary prophylaxis. We're going to give them something afterwards to prevent the reinfection from occurring there. And so we'll talk about some different instances. I'm not going to cover every single one of these, right? But I'll cover some of the more common ones that we think about in terms of prophylaxis for a lot of these patients. And guess what? We do a lot of this too for chemo patients. Why do you think we do it for them? We're similarly suppressing their immune system. You'll also see their white count go down, and they'll be at risk for the same exact sort of disease state. So you got to be really watchful for that. And not only that, but consider as well, do they have a latent TB infection? That can become reactivated as the immune system gets less and less functional, right? So again, as we mentioned that today our emphasis is on trying to prevent the infection in the first place and try to recover their CD4 count as best we can. And so in these cases, we try to prevent exposure to the opportunistic pathogens if we can, but we can't put our patients into a little hermetically sealed bubble, so that's not always going to be possible. And then if we can, try to vaccinate to anything. Now, ideally, when would you want to vaccinate these patients? Probably early on when they still have a competent immune system, right? So if there's anything they could be prophylaxed against, try to do it then. As their immune system becomes less and less functional, we'll find that the efficacy of the vaccines is also going to go down as well. And then we'll start up chemoprophylaxis when we reach certain thresholds. So as I mentioned, like PJP, we will start at threshold at around CD4 count 200, right, for instance. I'm not going to quiz you on that specifically, but I want you to at least know the disease states we'll talk about here. And then if they do develop an opportunistic infection, we'll go ahead and treat that as need be, and then we may put them on secondary prophylaxis afterwards until they actually recover their CD4 count. So maybe someone's first diagnosis of HIV is when they come in with a PJP pneumonia, right? So you treat them for that, and then afterwards you put them on secondary prophylaxis, put them on heart therapy, and then when their CD4 count recovers to a sufficient degree, you can then stop that at that point, because then their risk is fairly low, right? So, as I mentioned, this is not an all-inclusive list, but I definitely recommend checking out aidsinfo.nih.gov if you want more kind of up-to-date sort of recommendations on this stuff. So, as I mentioned, a lot of patients, not a lot, but some patients are going to be co-diagnosed with an opportunistic infection and HIV at the same time, because that may be the presenting sort of presentation there for them. Presentation doesn't make a lot of sense. That may be their initial presentation for this. And so there are a lot of benefits to helping them with their immune recovery by starting off antiretroviral therapy. What's interesting though is they may actually feel worse initially, because as they start to have that immune system kind of come back online, they're going to have a lot of inflammation associated with that. So they can't have this sort of this iris syndrome, this immune reconstitution syndrome that develops where they feel a lot worse, even though it's really just their immune system recovering. Be aware of drug interactions. So for instance, if you're getting your patient and you diagnose them with TB, and then you check them for HIV and that's positive, and you want to start them on ART therapy, look for those drug interactions there. You want to make sure one's not going to be trying to sort of inhibit the other treatments there. And so also imagine if you got diagnosed with TB and HIV at the same time, you're like, here's 7 new drugs you get to start all at one time. Like that would not be too fun in terms of compliance. So again, ancillary services are really, really helpful to help keep them compliant. And so again, with this iris syndrome, they will frequently find that the inflammatory cascade can be pretty severe, but we just treat this typically conservatively, antipyretics, analgesics, things like that to try to help get them through it as their immune system comes back online. So let's talk about PJP pneumonia, is formerly PCP or Pneumocystic carinii pneumonia. This is a fairly common life-threatening. If they do develop pneumonia from this, it can be what kills them in a lot of cases because it can be quite severe and difficult to treat, as you will see. Again, most people tend to get exposed all the time to this thing, and they'll never develop an infection because we have a competent immune system here. But you'll find that it can be, pretty insidious in terms of onset. You may just think, oh, they just have a cold, or maybe they just have a typical bacterial pneumonia. But guess what? A lot of your antibiotics will not be all that effective. Specifically for this, we're going to find that the treatment is going to be with Bactrim. Bactrim is a drug of choice for PJP pneumonia, so sulfamethoxazole, trimethoprim. Notice here we're treating for like 21 days. Is that pretty typical treatment time for like a pneumonia? Sound pretty long, pretty short? Pretty long, right? Why are we treating for so long? One, they may be immunosuppressed, so that way they're not able to help fight off the infection themselves, and two, it's a very difficult to treat infection, so we do have to treat them for a while, right? And so it's not uncommon these patients will end up being in the hospital for 3 weeks for treatment from this, and guess what? Guess what you get in the hospital if you're there for a while? You get a secondary infection from something else, right? You get intubated for this due to respiratory failure, and then all of a sudden now you got a pneumonia with Pseudomonas as a result of that. So this can be a reason for really prolonged sort of stays in ICUs and things like that. So, and typically what you'll find is for Bactrim, 99 times out of 100, we're always going to go with oral Bactrim, even if we need it for pretty severe infection. This is a case where we actually go with IV Bactrim. We actually don't mess around. So if you ever try to order IV Bactrim, you'll probably get a call from your local pharmacist saying, what are you doing? Don't do that, just do oral. IV in this case is actually definitely warranted for these patients here. It's really tough to get into solution. You have to give them a ton of fluids. It's not a great IV drug. But anyway, so for example here we may do prophylaxis if their CD4 count gets down below something like 300, or if they have a history of oropharyngeal candidiasis, similarly showing that they have some degree of immunosuppression, and that way we can go ahead and give it to them. If you ever see like thrice weekly Bactrim, or say like twice daily on Saturday and Sunday, that's typically for PJP prophylaxis, and you'll see a lot of chemo patients that are on that as well when they're neutropenic. They'll be on that sort of regimen additionally. And then we'll do secondary prophylaxis. If they actually develop the infection, we treat them for the 21 days, they recover, then we can put them on secondary prophylaxis, which is identical to primary prophylaxis in those cases. If they do have sort of a sustained recovery of their CD4 count, then you could take them off the prophylaxis at that point. So candidiasis or thrush, again, what kind of patients would you typically see thrush in from a medication? Inhaled corticosteroids for sure, but this is another case here. If you saw thrush, you want to be thinking, hey, is this patient immunocompromised to some degree? Because this is not a typical sort of fungal infection patient should get. The other big concern is that they get, especially like an esophageal sort of candidiasis, is that can translocate and become a systemic infection more easily in these patients than someone who had more competent immune system. So that's certainly a concern there. Frequently we'll give these patients things like nystatin. Nystatin's beneficial to either swish and spit or swish and swallow. Why do we like that one? There's no absorption, I don't have to worry about systemic effects, no drug interactions. However, if we are seeing more, say, invasive disease or more involved, like getting into the esophagus, this is where fluconazole is definitely going to be a drug of choice in this case here, either IV or PO, depending on the situation. The more disseminated the disease, the longer we're probably going to need to treat for. And again, think about the drug interactions that come about for that. A lot of the azole antifungals are going to inhibit CYP3A4, which can really cause some big interactions with our other medications there. So for this one, we typically don't treat with any kind of primary prophylaxis, but as soon as you see it, definitely you want to get on that and treat as soon as possible. There's a lot of other ones that are out there. I'm not going to cover in too much detail here, but things like cryptococcal meningitis and toxoplasmosis, all these things here, pretty significant, can be quite life-threatening in these patients, much more so than other patients who have a competent immune system, so you just want to be aware of that. Other complications we're seeing with these patients, though, is the fact that they're living longer. So we're seeing a lot of metabolic complications, and we're seeing more issues of them just aging. And so we see things like cardiovascular disease and hypertension and dyslipidemia, all those kind of things there. Not only that, but you also have to consider there's what they call this HIV-related nephropathy, and that can actually lead to some pretty significant renal dysfunction, which can affect a whole host of other drugs. So again, watching for their organ dysfunction as time goes on for these patients. Plenty of cancers that they're at risk for. Again, another thing you're going to see, the longer the time frame, the longer the bigger the risk is for developing one of these. And then just whenever you need to, double check for interactions, especially on any kind of heart regimens, because there's probably going to be at least one or two that'll flag as like a big orange label or a big red label. You want to be wary of those, right? Okay, any questions on that stuff? Anyone know why I put a car here? Yes, yes, I have an STI, as it turns out. So similarly, my wife, when she got into to the car the first time when I bought that, there's a little dial in the middle where you can change the center differential, but it's abbreviated. Guess what it's abbreviated as? C. diff. And so she goes, you just bought this thing and it's already got C. diff in it? And I said, yes, it does. But anyway, what we're really talking about, sexually transmitted infections. Did I tell you the story where I was yelled at a guy about his STI? So it was one time I was in this old neighborhood. This is probably the reason why I moved out in the first place. But I was going for a walk and I saw a guy in his garage. He had a similar car to mine. I said, hey, I like your car. And he goes back, thanks. And I go, I have an STI, to the whole neighborhood. And he kind of looked at me funny. I just kept walking. But abbreviations are funny like that. So anyway, so let's talk about a few of these sexually transmitted infections here. They're not related to the car. Gonorrhea would be the first one we'll mention here. It's a gram-negative diplococcus. Have you covered any STIs elsewhere? So you're already well versed in these in treatment? Yes? No. Maybe. I love the smattering of faces from no to yes to like, did we cover that? I was probably studying for something else, probably Pharm. What do you have test? What test is tomorrow? Right, so most of you are probably thinking about bones right at this point, but that's okay. Again, the video is there for you. So in terms of like kind of overall like treatment paradigms for STIs, what do we think about in terms of like treatment duration, adherence? What do you think? What kind of regimens we go with? Like really long, protracted sort of treatment regimens? No, we want things that are one and done. Why is that? It's easy. You're ensuring success with that one treatment because potentially these patients who have developed one of these STIs, they may be having behaviors that put them at risk for developing other STIs or giving it to someone else or vice versa. So this is typically where you're going to see a lot of these regimens here are going to be focusing on like one-time doses. You're ensuring compliance in that case because they got the dose from you, so there's really nothing else to really worry about. And we'll see some issues we have to go with like alternative agents. But well, that's kind of one of the caveats I want you to think about with a lot of these STIs here. Also, treatment of the partner can be quite important as well. So we'll see some instances where laws have been changed such we're trying to increase access for the partner of someone who is presenting and gets diagnosed with an STI, such that you may be able to write a script for that person even though you've never laid eyes on them in the first place. But starting out, talking about gonorrhea here, again, a lot of these disease states also tend to be asymptomatic, which also aids in their easy spread. If you just don't know about it, then it's much easier to spread in those cases there. Reasons why we don't like it in the long term tends to be things like more systemic infections, or you can see a lot of issues like pelvic inflammatory disease. It can lead to infertility and a lot of other issues. So not great from that standpoint. Also, you tend to find that patients with HIV also tend to spread, a lot of STIs tend to spread more easily in that population, mainly because, again, they're immunocompromised. They may not be able to fight off that infection in the first place. So for gonorrhea specifically, our treatment and the place to go to for any kind of treatment guidelines for STIs is always going to be the CDC. It's the best place to go to for up-to-date information on this, because some of the stuff does change over time, whereas other things stay pretty stable here. And so here's some good examples of really kind of rock-solid stable recommendations. So here they're going to recommend an IM single dose of ceftriaxone, 250 milligrams. That's not like a really big dose. Actually, not. Like, typical like treatment doses for like a bacterial infection, like for kids, I think 50 mg per kilo. Like 250 is like nothing. But they do find that for gonorrhea specifically, this dose tends to be very effective, especially when you give it IM, so you don't have to worry about bioavailability. Drugs all right there. And so they've tried, they've looked in studies to look at oral use of cephalosporins, but it just really had a lack of efficacy. Treatment duration was also longer, which was not great from that standpoint. So we just like to use Rocephin in those cases. You'll also find that chlamydia tends to go hand in hand with gonorrhea, a lot of co-infection in those cases there. And so it's recommended to go ahead and treat both at the same time. And so in this case, this is where like azithromycin, just a 1 gram dose, PO is the treatment recommendation. It's the first line regimen there. So if you ever see someone like in the ER, the urgent care getting an IM dose of Rocephin and then an oral dose of azithromycin, 1 gram, which is a fairly large dose, that usually is going to be for that gonorrhea chlamydia sort of combo treatment there. If you couldn't use something like azithromycin, that's where doxycycline comes into play. You'll see that tetracyclines tend to be a pretty common sort of backup agent here. They tend to retain a lot of efficacy against most of these STIs. So you can use doxy, say twice a day for 7 days. However, what happens to your compliance? Not great. Patients may not want to go fill that script, and they just never get treated in the first place. So it's ideally you like to do it in the office right there in the ER. If we have true documented cephalosporin allergy, we know the patient could not get ceftriaxone. There's not a lot of good options that are out there. We may try some fluoroquinolone, something like gemifloxacin, maybe IM gentamicin, but ideally if we can, try to go with ceftriaxone if at all possible. In some cases for infants, we'll actually give topical erythromycin because there is possibility for perinatal transmission. So that's where you might see topical erythromycin ointment being used in the eyes just to prevent that from that infection from starting. Then, as I mentioned with chlamydia, this is a quite frequent STD. It's actually the second most frequently reported after HPV. You tend to find a lot of these reportings, though, for things like STIs are going to be underreported. Many patients may either be asymptomatic or they may not seek treatment, depending on the case there. So it's probably twice what the rates I actually think there are in those instances. And this one also tends to be more asymptomatic than gonorrhea, which is why a lot of patients end up just getting co-treated. They get a gonorrheal infection, just go ahead and get treated for chlamydia at the same time. As I mentioned, you can use azithromycin as a 1 gram dose. You're one and done, don't have to think about it. Otherwise, things like tetracyclines, like doxy, tends to be most common. It's fairly cheap. Otherwise, a fluoroquinolone could be used as well. However, why don't we like tetracyclines in pregnant patients? A lot of things like bone, inhibiting bone formation, things like that, it affects calcium pretty significantly there. This is another case where you could actually end up using oral erythromycin for infants who are born in order to prevent a chlamydial infection there. So it kind of pulls a little bit of double duty. Next we have syphilis here, which is a spirochete, probably the first one we've actually encountered here. Treponema pallidum kind of sounds like a spell out of Harry Potter, right? A little bit. Again, this is another very highly contagious sort of disease. We really worry about, and what I see more commonly, especially for like in the ICU sort of setting, there's a lot of like the secondary complications. So things like neurosyphilis can be like quite difficult to treat, pretty problematic there. Here we're going to see that penicillin G tends to be the go-to. So this is going to be our gold standard sort of medication for syphilis. And again, it's one of those things where you think about resistance patterns. We've been treating syphilis for ever since Pen G came around, and guess what? Still retained efficacy. So from that standpoint, it's really a nice drug. We will find that, you know, again, if we can do one and done sort of regimens, that's always beneficial. And this is where bicillin comes into play here pretty significantly. So benzathine, penicillin G, if you recall back in our bugs and drugs section, it came in that little white sort of milky sort of solution. It's because it's an IM dose. It's a long acting formulation that will slowly release into the systemic circulation and provide nice consistent levels to treat that syphilis there. So again, single dose therapy always preferred. If you couldn't use that, this is where your tetracyclines can come into play. But again, treatment durations tend to be pretty prolonged, 2 to 4 weeks or so. And so compliance is always going to be the issue because patients will feel better and say, okay, I don't need it anymore. And all of a sudden, they can have recurrence. What we'll do for cases that may be more systemic or say like neurosyphilis is where we'll actually get admitted and we'll do continuous IV penicillin G. We'll actually give them like a continuous infusion, and that can be a pretty effective treatment for that in some cases. Next we have herpes. So we know that there's HSV1 and 2. HSV1 is typically associated with what? Yeah, oral sort of manifestations. HSV2 is more genital. However, can they switch? Absolutely, right. So it's not to say one is going to be either place. They're treated identically, so it doesn't really matter for our purposes here in terms of the medications. But again, another big reason for spread is because a lot of patients are asymptomatic from it. So it can really go a long time without ever being noticed. You can give it to multiple partners and just not know it. So ideally, if you do have patients, especially if they don't have any kind of apparent lesions, it's still, they can have viral shedding. So that's why even though they say, well, I don't have an outbreak right now, they can still give it to someone else. And that's why looking at the different treatment regimens is going to be really important here. So our goals, obviously, if they're having an acute outbreak, is to try to limit the sort of the pain and you know, kind of the pruritus and things like that associated with, try to shorten the course if we can, and try to prevent any sort of complications. So for instance, any kind of like, you know, CNS manifestations, things like that. And ideally try to decrease transmission to other people as well. It's always going to be preferred in those cases. In terms of just treatment for, say, pain and discomfort associated with those lesions, we're going to find things like, you know, sitz baths and analgesics. All those can be effective for that. They don't do anything to necessarily the duration or severity of disease, but they can help to deal with some of that symptomatic management. Really important to keep the area clean though, because you will find that secondary bacterial infections can occur, and then you got now something else to deal with on top of the actual the lesions there. So what do we do for these patients? Typically, we're going to go with an antiviral that has activity against the herpes virus, and so acyclovir and valacyclovir is probably going to be used 9 times out of 10 for these patients here. Typically, for the first sort of manifestation, you can give them about a 7 to 10 day regimen there, and one that's going to help to reduce the symptomatology, how long they're going to have symptoms for, and then also the viral shedding, so that way they're going to be less likely to spread it to other individuals if there is going to be a potential exposure there. So just with, when we talked about influenza, what do we talk about in terms of like when to start treatment? Yeah, like the sooner you can start, the better, ideally within 48 hours. Same thing is going to happen here. We want these patients to get treatment as soon as they start to develop symptoms. Earlier the better, because it's going to retain more efficacy against the virus there. We will find that topical treatment, like things like topical acyclovir, are not going to be as effective as systemic therapy. So most of these patients will end up getting an oral dose recommended for them in a lot of the cases there. Remember, immunocompromised individuals are going to be more likely to end up developing things like secondary, like more systemic infections, more CNS infections. And so this is where things like IV acyclovir can be recommended for them in a lot of cases. They have like, herpes encephalitis and things like that. That's where IV acyclovir comes into play. Keep in mind, it's really important to recommend patients who are taking acyclovir to keep well hydrated, because we worry about the drug crystallizing out in the urine. Make sure you're drinking plenty of water. Seeing more with like systemic IV doses, you're going to see more things like bone marrow suppression can be a possibility. So just be aware of those risks associated with the drug. So there's kind of two regimens. So say you get through that first outbreak for the patient there. Now we're kind of considering, okay, well, how do we kind of manage this going forward? Because obviously once they have it, they have it. So do we do more episodic therapy when patients sort of develop symptoms, or do we do, say, chronic suppressive therapy to try to prevent recurrences from happening? What do you think? What would you rather do? Episodic? Okay. Anyone for chronic suppression therapy? Not at all. Interesting. Okay, one maybe, half a hand. So typically with episodic therapy, you're going to have them sort of have like an as-needed script. They'll have it available to them when they start to notice symptoms. Usually they'll have some kind of prodromal symptoms that they'll notice about it, and then they can start early, ideally within the first 24 hours. So this is something you'd want them to say, hey, if you have another outbreak, have this available to them. You don't want them to wait to come in, because then you might miss that sort of 24-hour window. So this is better for patients to have, say, when they have more severe symptoms when they do occur, maybe they have more prolonged recurrences, like a long healing time. This may be more beneficial for them. However, keep in mind that these patients still may shed the virus even if they don't have any obvious lesions there. So one of those like kid memories you have, I always remember, is like very like significant in my mind, was watching like daytime TV, and you see those drug commercials. I remember seeing the Valtrex commercials when they were first coming out, and it showed all these people that were like kayaking and they were like skiing and having a lot of fun. And I was like, what does that have to do with herpes? But they always said, even if you don't have an acute lesion, you can still spread it to other people. And that always stuck out in my mind in that commercial for whatever reason. So I tell you now so that you remember that as well. The other way you could do it, though, is use chronic suppressive therapy. And so basically this can be helpful to reduce those recurrences. So maybe if they have maybe frequent recurrences, this may be a better option for them in those cases there. So you also tend to find less asymptomatic viral shedding. And so the idea is that there's a potential for less spread to other individuals if you're taking something like Valtrex every single day. Again, I don't know if we have the full story on that yet. If we have the studies to support that, that's going to help actually decrease spread, but it's something to consider. So especially if they have a partner who does not have HSV yet, maybe it may be useful to use more suppressive therapy chronically. Up next, we have trichomoniasis, which is a protozoa, a pretty common one here. You're going to see this tend to be more reported in female patients. The guys tend to have a high spontaneous cure rate, and it's easier to transmit from men to women in a lot of situations there. Treatment here is going to be one of the two, either metronidazole or flagyl, or you can use tinidazole, which again is kind of a newer one for us, but it's another antiprotozoal drug here. You can just use a single 2-gram dose of either, and that will be enough to go ahead and treat that. Again, one and done is the mantra here. This is one of those cases where you could actually you have a male patient who is, you're seeing a female patient, but their male partner is still having the disease state, and they can just spread it back to the female. So this is a case where you could actually write a script for the male partner, say, okay, you can go and get treated, pick up this prescription, get rid of it, without ever actually seeing that person. So the laws have kind of been changed to reflect that, which is nice. So, any questions on any of that? It's kind of quick, but it's kind of breezing through it. You get a lot more of this with OB-GYN, I believe, with Professor Lack in a little bit. Any questions all yet? I don't want to go through this just yet. My liver's calling out to me and says, maybe.
Is that your stomach or your liver?
I don't know, hard to tell the difference sometimes. See if there's any oh my goodness, look at all these questions. This is going to take way too long. I should probably... Yeesh. Why am I being so nice to you guys? You guys made a mockery of my test. Oh, terrible. We're doing so well on it. All right, have you ever seen someone on oral nystatin in the pill form? What was the mechanism with that? How does it work? I have not actually. I've seen the powdered form being applied to like stoma sites before because that kind of helps out with any kind of like sort of candidal infections there. I've seen the liquid being used most often just because, again, when you're trying to use it either for treatment or prophylaxis, you want that kind of coating effect there. I've not seen too many of the nystatin tablets, to be honest. I don't think I've worked in a pharmacy that actually carried it at all, which is interesting. But the patient on chemo and heart, how would you manage suppression of their immune system? I'll put them on lots of prophylaxis, maybe like put them in a big hermetically sealed bubble and say like don't have any fresh fruits unless you can peel it, no flowers, anything like that. I don't know if I've encountered that specific instance. I'm sure it's occurred. But yeah, you definitely want to watch that immune system because, again, if you're giving chemotherapy, it's going to knock that down. That's going to be an issue. So that's a very good question for someone, maybe like an ID doc and an oncologist together. If you get like a panel, they can bounce ideas off one another. But an ethics question. I'm terrible at these. Never been accused of being ethical, but I know you can mix IM ceftriaxone with either water or lidocaine 1%. What are your thoughts on deciding what to mix with the antibiotic based on patient story? Example, patients married and cheating on a spouse. Do you think it's ethical to purposely let them feel pain of the shot when mixed with water? Oh my goodness. I believe you should never inflict undue pain on your patient regardless of why they're there to get treatment. I think that if you feel the lidocaine is a good option to help reduce pain, then go for it. On the other hand, though, some people feel, well, why have unnecessary drug exposure? Why give them the lidocaine if they don't really need it? It's a one-time shot. It can't be that painful, right? I don't know if there's a clear answer for that one, but if you feel like the lidocaine is not going to pose any risk to the patient and it's only going to benefit them, then I say go with the lidocaine at that point there. How about that? Seem reasonable? Toe the line. Interesting. Don't use this against me later on if I'm wrong. If a patient starts taking acyclovir and has a bad reaction, I heard you can play guitar. What? It's a weird segue. No, I will not. I was like, how would playing music help with the reaction to the acyclovir? But negative. Okay. All right, that's it. I'm definitely cutting it off now. So, any other questions before I let you go? If not, enjoy your lunch.